All right, so let's take a look at field and clinical learning. There's a lot to be said about being a good preceptor, and sometimes those things go hand in hand and sometimes they don't. Sometimes people are really good preceptors, but maybe not good formal educators, and that's okay. Sometimes people are really good formal educators, but not good preceptors. And it's really important that we try to be good at both, right? Because what you teach in the classroom also needs to be backed up with what you're showing, what you're demonstrating, especially out in the field. And you want to make sure that you're setting that good example and giving that good feedback while still allowing the student the opportunity to kind of explore and make mistakes in a safe environment. So the goal here for this lesson is to look at the instructional theory and strategy focusing specifically on clinical education, that is education that is experimental and involves the student observing, participating in, or leading patient care activities in an actual hospital or field patient care setting. So you guys know that depending on where you're at and what stage of your clinical process depends on where you're going to be at with that. Are you observing? Are you just watching? Are you participating? Or are you leading the patient care? Generally, when you're first getting started, you're observing quite a bit. You maybe do a few things here or there by participating, but mostly observing. And then as you gain some skill set, you start to participate. And then when we're talking specifically about paramedic students at the end of their clinical career, as they're getting ready to graduate, they have to go through a capstone phase. And that capstone phase is really essentially putting them as the lead provider. They've got to be the team lead on all of these patients that they must come into contact with, and that's 20 patients if they're using the COAMPS accreditation model. So just taking a look at how that can progress. A clinical educator refers to all persons who guide experimental learning, including mentors, preceptors, and training officers. So there are a ton of people that a student may come into contact with in a clinical setting that could influence their education and their future career. An educational institution may have a clinical coordinator who arranges and oversees students' clinical sites and opportunities. And so like for us at JCC, that's Mark, who arranges all of the students' opportunities, and he's kind of their point of contact. But there are dozens, if not hundreds, of preceptors that we come into contact with regularly, and some better than others. Some enjoy the opportunity to teach students and guide students more than others, and that's okay. But it's kind of all of our job to get that feedback from students, get that feedback from preceptors, and kind of determine what kind of improvements we need to make. The goal of an effective clinical educator is to help transition the student from a theoretical environment of the classroom to the real world of patient care delivery. So that means I can teach a student how to do splinting and how to do hemorrhage control and talk about, what does this type of bleeding look like? Is it venous? Is it arterial? But it's not until they get out in the real world and they see this firsthand that goes from a what if scenario to now I know how to identify it. And so much of EMS education is that way. And I tell my students that all the time, when they ask, how do I know? How do I know when I need a non-rebreather? How do I know when I need to ventilate a patient, not just based off of numbers? How do I know if they need a nasal cannula over a non-rebreather? How do I know if this particular lung sound is wheezing and rails, or if it's just wheezing? There are so many things that they have questions about, and so many times you have to say, I can't tell you. I can't tell you until you're there. This is something that you gain with experience. I can let you listen to lung sound clips over and over again. I can give you a million scenarios, but it's not until you develop that gut feeling that you truly begin to become a good clinical practitioner. And you guys all know that and know that feeling. So being able to pass that on to students is really important. In addition to being a role model and demonstrating excellent clinical skills and behaviors, the clinical educator must be able to recognize and take advantage of opportunities for the students to try a skill or learn a lesson from existing circumstances, aka a teachable moment that creates long-lasting retention of student learning. And I've got a little secret here for you. Sometimes that is failure. Sometimes it is letting a student get the answer wrong. Now, that doesn't mean that we want to do that at the expense of our safety or the safety of our patient or the safety of the student, but asking them questions. And I have found this time and time again, if a student feels upset, for getting the answer wrong or embarrassed. And I don't mean intentionally embarrassing them, because certainly we never want to do that or degrade a student. And we're going to talk about how important it is to build positive and trusting relationships. But I would use myself for an example. When I was a paramedic student and I was being asked questions about medications, and I can tell you one in particular, amiodarone, and I was struggling to remember all of the indications, contraindications, and every little detail about the medication. And my preceptor asked me the questions repeatedly over and over, and then asked me in front of other people. And when I got it wrong, I was so embarrassed. I never got it wrong again. So again, not intentionally embarrassing or degrading the students, but sometimes it does take something like that for them to commit it to memory. And we'll talk about the differences between formative and summative learning in the next PowerPoint, where you really have the opportunity to take a step back and say, is this a time for the student? Is this a teachable time where I can still form their education, or should they already know it? In that case, we'll be doing a summative evaluation, and I don't need to give a lot of feedback. This is a pass or fail moment. So identifying those teachable moments and letting them learn lessons is a really big deal in the clinical setting. The clinical education should be performed under the supervision of an experienced clinician who facilitates learning while being responsible still for patient care. And so this is a big deal here as well, knowing where to draw that line and say, I am still responsible for what happens here, but I'm going to let my students step in. I'm going to oversee, and I'm going to carefully watch everything that they're doing. But I'm, at the end of the day, I'm still responsible, but I'm going to let them try their hand at this assessment or this, medication administration or whatever it is. Clinicals should still be a safe and supervised environment, but and still an opportunity for students to learn. And so we've got to understand we can't just completely turn over patient care solely to the student without being very aware of everything that's happening here, without still asking questions. Sometimes it's difficult for preceptors to take that step back. They don't want to allow students the time and opportunity to step forward. And we know that time is of the essence in some of these situations. Sometimes, it is a true emergency and you don't have time to waste. Usually what I try to do is have my students, I give them an opportunity. And if after a couple of minutes, I don't see that they're progressing with their questions or their assessment, and it seems that they're stumped, then I might step in and ask a question. If it's a life-threatening situation and the student is very overwhelmed and not able to take lead on that, then of course, you want to jump in. But give them an opportunity to find their way, even if they seem like they're stumbling. Looking at some of the roles of a clinical educator, we want to size up the needs of the student, assist the student in creating a plan to facilitate learning. So by now we know that not everybody learns the same way. Some people learn better with flashcards. Some people learn better with teaching things to someone else. Some people learn better in scenarios. Some people prefer to write stuff down or watch videos. So help figure out what's going to work for this individual student. And just like when we talked about what works for an educator in the classroom, how you learn is generally how you teach. And that's much the same for your preceptor role in the clinical field as well. How you learn is most likely how you will teach here. But you want to be open to the student and see what they need. Okay. And so that's why working with the same student over and over can be so beneficial. And we'll get to that here in just a minute. We're also going to help the student put that theoretical knowledge into practice. So again, they've seen these heart rhythms over and over again in ACLS maybe, and they're here to identify these rhythms. Okay, well now you identified this as a rhythm, but now what? Okay, now what, how do you know? What medication do you use, or should I shock it? Again, those things that you gain in a clinical role, in a clinical experience, that's what they're here to get. So you're going to help them put that theoretical knowledge into practice. You're going to extend their knowledge and learning by relating experience back to general theory. So again, just tying those pieces together. Promote their skills development, promote professionalism, and one of the best ways that we can do that is by demonstrating it ourselves, being professional ourselves. Providing feedback to learners about progress towards goals and objectives in the clinical area. So again, if you have the same student multiple times, letting them know, hey, I see your progress, you're getting better. What we're working towards is really happening here. Be responsive to the needs of other clinical staff, so don't just completely cut off your partner or your other crew members. You're still here as the lead provider. You want to evaluate, document, and report student progress and achievement. Don't be afraid to send those emails to the instructors, to clinical coordinators, and just say, hey, this student did a great job today. I can't say it enough. We love to get that feedback, and I say that, from an instructor standpoint. It makes me feel good. It makes the students feel good. They need that positive reinforcement. But on the flip side of that, don't feel bad about reaching out if something went really bad. Of course, just like with your personal life, or if you have your own conflict at work, the first thing you want to try to do is resolve that with the student. But if it was truly a critical error, or you feel like for whatever reason you can't speak with the student individually, then please come forward and make those concerns known about the student. We definitely want to hear that too. Promptly report concerns to the program if the significant performance or behavior issues occur. Again, very important for us to get that documented in their file. Not to say that, every small, minor inconvenience or oversight of the rules necessarily means a student will be dismissed from a program, but they definitely need to be addressed. The clinical educator must balance the instructional needs of the student with the needs of the patient, their bystanders, family members, support staff, and coworkers. Being a preceptor is not a small undertaking. This is a very big role that we are asking for people to feel. If you're a preceptor already yourself, then you understand the struggle that can be sometimes to kind of balance all of these pieces of the puzzle together, where you're caring for the patient, being responsive to the needs of your partner, but also not shutting the student out. So important that we are being respectful and professional and kind of meeting all of these needs. And that's, again, big shoes to fill. Some ways that we can help reduce the student's anxiety in a clinical setting: establish a safe relationship. Be honest, build trust with them, deal with mistakes calmly, and emphasize their positives. Let them know what they're doing right. Let them know what they're doing wrong, but in a way that is going to help them build, not make them turn away from you. Because if they don't trust you, then they're not going to feel safe here again, and they're not going to be willing to make those mistakes. They're not going to take the opportunity to provide answers for fear that it might be wrong and that they might make themselves look stupid in front of you. So build that trust, build that safe relationship with the student. Build self-esteem for the student. Again, encouraging their positives and building that trust. Confront the problems, talk about their anxiety, what they have going on. Draw from their past coping mechanisms, whether that's EMS related or not. If the student appears blocked, give them very specific directions. So again, if you're in that critical situation and you see that the student is frozen, don't wait for them to try to figure out what to do. Give them direction. And then after the call, break it down and talk about it. Set strict limits and insist the student attempt or try to perform. And this is, again, going to really vary depending on where the student is at in their coursework. If you're just starting out, then you're probably not going to do this. You don't have to insist that they attempt. You might offer it, but not insist. As they progress forward, when you get all the way up to that capstone phase again, and they're acting as the lead provider, if they, take a look and they say, no, I don't think I can get an IV, if you see something that you feel would be, and I'm just using that as one example, something that you would be able to get an IV on, instead of doing it for them, ask them to try, ask them to perform, make them step up to the plate. Divide tasks down into smaller parts and set realistic expectations based on their knowledge and experience. So again, knowing where they're at, knowing their history, and again, going back to talking about working with the same student over and over so that you can give a good feedback on their progress is really important. Also, you'll already know what they know and what type of calls they've been exposed to. And so reducing that ratio as the number of preceptors to students, very important. Used to, when I was in paramedic school, we could have any number of preceptors. I worked with some preceptors only one time. I worked with some more consistently. But now, keeping that ratio small per the COAMP standard is is really been helpful and shows a lot of progress, and it helps build that mentorship too, and gives the student someone to look up to, someone to learn from, someone that they trust. And so COAPS actually recommends a 1-to-1 ratio, meaning only one preceptor per student, one person that you learn from. But obviously we realize that that can't always be the case. People call out, people get sick, people take vacation. And just to give the student schedule some flexibility. So ours personally here at JCC is 4. We try to keep it at 2, but we do have that flexibility to go to 4 if we had to. So 4 preceptors to 1 student, still not a bad ratio to learn from. I'm going to stop this portion of the video here, and I will catch you guys in part 2.